Hi friends, today I will talk about hypertension in pregnancy. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided here is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of a medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. If we see the definition of hypertension in the pregnancy, it is defined as when the systolic blood pressure is more than equal to 140 mm of mercury and or diastolic blood pressure more than equal to 90 mm of mercury. And severe hypertension is when the systolic blood pressure is more than equal to 160 mm of mercury and diastolic blood pressure is more than equal to 110. Severe hypertension, it increases the risk of stroke, maternal morbidity and mortality, and making early detection and treatment essential. Hypertensive disorders in the pregnancy, they complicate approximately 11% of the pregnancies, and if we see the distribution, 4.7% cases they end up with preeclampsia, 3.8% as gestational hypertension, 1.7% as chronic hypertension, and unspecified hypertension account for 0.6%. But before proceeding the hypertension in pregnancy, we should do the accurate blood pressure measurements. For this, uh, patient should avoid caffeine and nicotine for at least 30 to 60 minutes before measurements. He should use the correct cuff size. He should ensure proper posture. He should be seated comfortably, back supported, feet flat on the floor, arms supported at heart level, and we should measure the BP after 5 minutes of rest and always use a validated BP device. For diagnosing the hypertension in the pregnancy, the initial evaluation should be done like urine test, urine for protein, urine sedimentation examination. In the blood, we should do the serum creatinine, CBC with platelet count, LFTs including the AST and ALT, and additional tests may be required at times like we have to do the blood glucose, electrolytes, serum fibrinogen level, LDH levels, bilirubin, complement level, serum calcium level. These all investigations they help identifying the preeclampsia, end organ involvement, and alternative diagnosis. Screen for proteinuria, renal dysfunction, thrombocytopenia, and liver involvement in all pregnancy cases with hypertension. If we see the definitions of the hypertensive disorders in pregnancy, gestational hypertension is new onset of a systolic blood pressure of more than equal to 140 mm of mercury and diastolic blood pressure of more than equal to 90 mm of mercury on at least two occasions 4 hours apart after 20 weeks of gestation in a previously normotensive individual and no proteinuria is there. Preeclampsia is when patient has gestational hypertension and proteinuria. Proteinuria is more than equal to 300 milligram per 24 hour or new onset hypertension without proteinuria and features of severe disease is present. Preeclampsia with severe disease means preeclampsia and the presence of any of the following findings are features of the severe disease like systolic blood pressure more than equal to 160 mm mercury, diastolic blood pressure more than 110, thrombocytopenia means platelet count less than 1 lakh, impaired liver function test as indicated by the transaminase levels at least twice the normal concentration, AKI with serum creatinine of more than 1.1, pulmonary edema, persistent cerebral and visual disturbances. Eclampsia is generalized seizure in patient with preeclampsia that cannot be attributable to other causes. HELP syndrome, hemolysis, elevated liver enzyme, low platelet. There may be hypertension in these situations and it is frequently seen as a form of preeclampsia. Chronic hypertension can be present before 20 weeks of gestation or in a patient with known pre-pregnancy or hypertension diagnosed during pregnancy that persists more than 12 weeks of postpartum. Chronic hypertension with superimposed preeclampsia, chronic hypertension with superimposed preeclampsia with severe feature, or other forms of hypertensive disorder in pregnancy. Why do we classify, or what is the need for classification of hypertension in the pregnancy? Because if we correctly identify the type of hypertension in the pregnancy, it we can delay the risk of maternal stroke, or we can delay the treatment if we do not classify, and this will increase the risk of maternal stroke, heart failure, organ dysfunction, fetal growth restriction, and perinatal morbidity and mortality. When should we start antihypertensive therapy? If the patient presents with severe hypertension in emergency, means her BP is systolic more than 160, diastolic more than 110, and it should be confirmed within 15 minutes. We should immediately treat to reduce the risk of stroke, heart failure, maternal death, and preferred drugs are IV labetalol, IV hydralazine, and immediate release oral nifedipine. If we get a patient with severe hypertension in the pregnancy, if IV access is feasible, then we should give labetalol 20 milligram IV over 2 minutes. If severe hypertension persists at 10 minutes, then we have to double the dose, 40 milligram IV stat. If severe hypertension still persists at 20 minutes, 80 mg IV stat. If severe hypertension persists at 30 minutes, 80 mg IV stat. If severe hypertension persists at 40 minutes, then again we have to give 80 mg IV stat. Maximum cumulative dose of labetalol is 300 milligram in 24 hours, or continuous infusion can be given at a rate of 1 to 2 milligram per minute. And still, if the hypertension persists, we can go for hydralazine 5 milligram IV over 1 to 2 minutes. Severe hypertension persists at 20 minutes, we can increase the dose to 5 to 10 mg. Severe hypertension persists at 40 minutes, 5 to 10 mg. Maximum cumulative dose of hydralazine is 20 to 30 milligram per treatment event. If still severe hypertension, we can start nicardipine 5 milligram per hour IV infusion, titrated up to 15 milligram per hour. If the blood pressure resolves or hypertension resolves, then we have to monitor the BP closely. If the patient's IV access is not feasible or not there, then we can give nifedipine immediate release tablet 10 milligram oral. Severe hypertension persists for at 20 minutes, when we can again give 10 to 20 mg. If still patient has severe hypertension at 40 minutes, we can give 10 to 20 mg of nifedipine. Maximum cumulative dose is 15 milligram per treatment episode and 180 milligram per 24 hour. If severe hypertension persists, then we will have to give her labetalol, and if severe hypertension resolves, then we can monitor the BP closely. Blood pressure target in acute severe hypertensions are, usually we have to set the goal and we should reduce the BP gradually. Do not decrease the MAP by more than 25% within first 2 hours. Target BP should be systolic blood pressure 130 to 150 mm of mercury, diastolic blood pressure 80 to 100 mm of mercury. Note that we should avoid overly rapid BP reduction, as it may decrease the uteroplacental perfusion and compromise the fetal oxygenation. In refractory cases, if BP remains uncontrolled, then we can use labetalol, hydralazine, nifedipine. If the patient doesn't respond to labetalol, hydralazine, nifedipine, then we have nicardipine if infusion or esmolol infusion can be used. All such cases where the blood pressure is controlled in severe cases are patients who have hypertension in pregnancy, or when the patient is stabilized and patient's delivery is not imminent, we can start the oral antihypertensive therapy. With that oral antihypertensive therapy, the acceptable BP targets are Most guidelines they recommend that blood pressure should be 140 by 90 mm mercury. It should be less than 140 by 90. But practical target, we should, different guidelines have different targets, but practically we should aim for BP reduction to less than 140 by 90. So prefer oral antihypertensive drugs are labetalol, extended release nifedipine. Additional options are adrenaline, methyl dopa. Methyl dopa is safe, less potent, but it causes sedation. So these are the oral maintenance therapies in the pregnancy. Labetalol, it is a alpha and beta blocker. 200 to 800 milligram in divided doses can be given. Nifedipine is we can give as 30 to 90 milligram once daily. In methyl dopa 250 to 1000 milligram in 2 to 3 divided doses. Hydralazine 50 to 100 milligram in 2 to 4 divided doses. These are the oral maintenance therapy. So if the patient has hypertension before pregnancy and they are planning the pregnancy, we should achieve optimal BP control before the conception. A patient should receive counseling regarding maternal and fetal risk, and they should continue or switch antihypertensive therapy based on the pregnancy safety. Antihypertensive drugs considered safe in the pregnancies are, I have already discussed, labetalol, nifedipine, methyl dopa, hydralazine. Optimize BP control before conception and use pregnancy safe antihypertensive drugs whenever possible. For non-severe hypertension, again the target is less than 140/90. If the patient has BP more than 140/90, then we should start the treatment. This will definitely reduce the risk of severe preeclampsia, placental abruption, preterm birth, and neonatal morbidity and mortality. If we see the gestational hypertension, if the BP is more than 140, 50, 159 and diastolic 100 to 109, we should start antihypertensive therapy if the delivery is not expected within the next 24 hours. If BP is 140 to 149, diastolic 90 to 90 mm mercury, we should strongly consider the treatment if pregnancy is likely to be continue for days or weeks. Consider early treatment in women with heart failure, chest pain, dyspnea, severe headache, visual disturbance, and confusions. So these are the all drugs which are given. The drugs which we should avoid in pregnancies are beta blockers, as atenolol causes reduced placental weight and reduce fetal growth. Propranolol should also be avoided because it may increase the uterine irritability. We should avoid ACE inhibitors, ARBs, and direct renin inhibitors like enalapril, ramipril, losartan, telmisartan, elkisarin. Their use is associated with fetal renal damage, oligohydramnios. Oligohydramnios. Fetal complications especially are seen in the second and third trimesters. Mineralocorticoid receptor antagonists like spironolactone, eplerenone, amiloride, they should also be avoided because spironolactone crosses the placenta and it has potential anti-androgen effects on the male fetus. Eplerenone and amiloride, they are not routinely recommended due to limited pregnancy safety data. So if we see the take-home message, we should differentiate the chronic hypertension, gestational hypertension, and preeclampsia carefully. We should treat all the severe hypertension cases. The aim of BP reduction should be less than 140 by 90 mm mercury during the maintenance therapy. Labetalol and nifedipine are the preferred agents in the pregnancy. We should avoid ACE inhibitors, ARBs, direct renin inhibitors, beta blockers, and spironolactone during the pregnancy. This is all. The good physician treats the disease. The great physician treats the patient who has the disease. It is a well-known quote by the Sir William Osler. Thank you. Keep learning.